Karishma to call up the next star speaker, Dr. Dennis Lam.
Dr. Dennis Lam, sir, he is here. So we'd like to interrupt the regular flow and request him to give our keynote address, new developments in Phaco surgery, which is the Zepto link capsulotomy and light adjustable IOL. Over to you, sir.
Yeah, thank you very much, Chair ladies. Ladies and gentlemen, today I'm going to talk about challenges and advances in Phaco surgery. Here's my financial disclosure. In particular, I would like to thank Professor David Chan for his video. So basically, I will be talking about some advancement in modern cataract surgery and then go straight to the two technology that I'm going to share. One is light adjustable IOL. The other is the Zepto link octo capsulotomy. So for advancement, I think we are all very familiar with from the machine and then to the femto-assisted laser, so on and so forth. So in fact, for Phaco, it was started in 1967 by Charles Kelman, and nowadays in developed places, Phaco is the main stage, and even in developing countries, Phaco is getting more and more. And then for the flex, the femtosecond laser-assisted surgery, it was founded in 2010, so they have a number of functions. The problem is that it incurs high costs, and so the availability and the accessibility may not be too good. And the other key issue in cataract surgery is presbyopia after cataract surgery. So the premium lenses is one main solution. So no matter you are talking about multifocal IOL or talking about EDOF, they still have their limitations, especially about the optical, the quality aberration from glare, halo, and to starburst, so on and so forth. So actually, monofocal IOLs plus monovision, or sometimes we call it blended vision, because you are actually having some very functional stereopsis. It's not really mono. So in our part of the world, we call this blended vision. So no matter it's for distant, intermediate, or near, over 60%, sometimes even up to 90% of the patients can achieve functional spectacle independence. So it is still a common strategy to address presbyopia. But then you have the problems of the predictability of the post-op refractive outcome, and also there is some variability among different patients regarding to the adaptation to the anisometropia. So by and large, up to 2 or 2.5 diopters, people can adjust. But sometimes, some of them, they can only tolerate maybe 1 diopter. So it's an issue. And before the surgery, you cannot make a very good assessment because you still have some residual accommodative power. So the unmet needs at least 3 of them, and today I'm going to talk about the first is light adjustable lens. So I heard about this more than 20 years ago. At that time when I heard about it, I think it's such unimaginable, because you say that after surgery you put UV light and then you can adjust the power. Actually, this is developed by a Nobel laureate in chemistry because you are talking about surface modifications. So if you are comparing a fixed optic IOLs to that of an adjustable lens, and then the advantage is quite obvious. So the normal routine is that we look at the patient and then we recommend the type of surgery, multifocal EDOF or standard IOL monofocal. And then you make all the assessment, and then at the end of the day, for this light adjustment IOL, you will have the opportunity to adjust the power, the refractive power after surgery, no matter you are talking about spherical or astigmatism. So this is the lens that being used. And this lens, the range, you can see that is quite a wide range from -2 diopter of the lens to plus 24. And then the concept is that the surface of the lens have this macromolecule coating in which you shine the UV light, then you can make changes. They have some photopolymerizations and leading to the change of the shape. As we all know, when the shape is changed, then we can achieve different refraction. So basically, you can see the process is like this, from the standard implantation all the way to the adjustment of the refractive power, and then you lock in, make sure that the refraction will not be changed. So indication, and by and large, you have to have a well-motivated patients, and then especially for those who have previous corneal refractive surgeries, because the refractive power after surgery may not be that accurate. And then these are the outcomes. You can see that it's much closer to plus or minus 0.5 diopters. And by the way, we have LAL and then LAL plus. For the LAL plus, in the central 1 millimeter diameter of the lens, they have a little bit of 1 plus, and therefore it's also good for good for correcting some presbyopia. And you can see here that the results when compared with that of other lenses, they have really good results. And in Hong Kong, our group has started this about 6 months ago, and over 30 Hong Kong doctors have used this. And then the results from what we get has been really very encouraging. And here, I would like to share with you one particular patient. Now, the patient wants to have some monovision, but it's a mini monovisions. So the target is one eye is plano, the other eye is -1. So after we achieved that, the patient was very happy already. But I said that before we log in, I put another plus 0.75 lens in front of him. And suddenly, he said, wow, it's much clearer. So we make further adjustment, and then we get the results of minus 1.75 in one eye, the other is plano, and then this patient is totally glasses independent. So this is the beauty, because before the surgery, you cannot make a full assessment of how much the patient can tolerate. Now, another few minutes is about the Zepto link. Capsulotomy, as we all know, is something very important for cataract surgery, and this is a new device. So I have an animation for you. So capsulotomy, we can use the standard one. We are doing it, and most of us are really expert and excellent in achieving a nice capsulotomy. But if you look at the edges, if we are using this small machine, the edges will be better, and visual alignment is very important. Because the device is able to make very good centration. So we have a handpiece, and then we have the ring. The ring has something called the nictino cutting element, because basically it's full delivering electrical pulses to the ring. We can see that. So this is an actual operation. So standard Phaco main wound, and then you insert this ring into the eye. Of course, you have viscoelastic, and then you can see the bubbles. Because when you apply the suction and then you press the button, the electrical pulses will create some heat, and that converts into some bubbles. And then the suction release, and then you get the Zepto ring out of the eye, and that's done. So, so you oppose to the anterior capsule, and then you apply suction, and then the electrical nano pulses deliver to the Nintendo ring, and then rapid temperature rise with some bubbles formation, and then you have mechanical cliffage. So here is a video courtesy from Professor David Chen. You can see that if this is a Phaco, the pupil is small, you can do the femto-assisted Phaco. Yeah, but for this, you can, use different types of iris hook or whatnot, and then you get the pupil a little bit larger, and then you do the standard Zepto link capsulotomy, and then you do the standard phaco. So you can see that, yeah, it's, the capsulotomy is very nice, and even though you have white cataract, and then you do the standard, and then you will get very nice capsular opening. So this is well demonstrated when you add in the dye. Yeah. And it's in all conditions. So it's not just about white cataract. It's, say when you have anterior capsular problems in pediatric cataract, yeah, or when you have a Mongolian cataract, you're afraid of once you have the puncture, then you have the splitting of the capsule leading to the Argentina side. So this is one case. So you just get in and apply the energy, and then you pull it out. Then you continue, you can see all the milky substance. Then you just continue with the standard operation. So in fact, if we are just talking about capsulotomy, this is more versatile than that of the femto-assisted one. And the results has been very encouraging from physicians and to the lack of complication. And you compare Zepto with femto second laser as well as manual capsulotomy in terms of the cost, accessibility, and results, they are all very good. And nowadays, the company is hooking this up to the Phaco machine. So this becomes very convenient. Yeah, so this is one operation by Professor David Chen. You can see it's hooked up to a Phaco machine, and then you just like, instead of receiving a pair of capsulorhexis scissors, you are receiving this handpiece, and then you finish that in a matter of seconds. So for Zepto Link is a safe automated capsulotomy technology, and with much lower cost. So it can use the reusable handpiece and then disposable ring, as well as hooking this up with the Phaco machine. So maybe if this can be further developed, it could become the standard. Of course, menu is always one choice. Yeah. Thank you so much.
Thanks a lot, sir. Excellent talk. Expert person on Dr. Karishma would like to ask you some questions.
Sir, what percentage of your patients have started converting into the light-adjusted IOLs? And do you
we started this about 4 months ago in Hong Kong. In fact, for my patients, this is my first choice. Yeah, if they can afford the the lens, because we have some additional costs for the lens. Otherwise, I think this is the first choice for my patient. For me, very busy. So I do a phaco surgery, maybe 5 to 10 minutes. But then, after surgery, you have to make this adjustment. I think the time, the results worth my time. Yeah, and actually in America, the adjustment is not done by doctor, it's done by optometrists. Yeah, because it's something very straightforward. You put up the contact lens, and then you put in the data, and then you press, and then in 60 to 120 seconds, it's done. Yeah.
And how many adjustments are possible for this?
For example, astigmatism. Yeah. Previously, we will mark the eye on the slit lamp to avoid this positional rotation. Now we don't need anything. We just go in to do the surgery. And post-operatively, you have the wound-induced astigmatism. You have the original astigmatism. We don't bother. Then we just wait for about 3 to 4 weeks. Time's up. The wound healing is relatively complete. Then we go straight to the adjustment. And then for the refraction, yeah, if you want to achieve, say, a panel, then you target a panel with the lens, and then when you make the adjustment together with the astigmatism. And the good thing is about the monovision. As I have mentioned, one eye is panel. The other, I'm not sure that if I put -2, most of the patient will be happy. But some of the patients would not be happy. And also, you have refractive surprise. But now I'm really at ease. I just do the normal phaco and then let the refraction be. And after that, I make the adjustment. Most of my patients, they only need one adjustment. Yeah.
That's very interesting. I think that's
Yes, it's something very
futuristic.
interesting. Yeah.
Very interesting, sir. Thanks a lot for
Yeah.
the keynote address. I would just
Thank you so much.